Hello, can we start?
I was waiting for Dr. Chafle. He said he'll join in 2 minutes.
Okay, no problem.
Dr. Anil, please let me know once you start, so I will start the recording.
Yes, yes.
Okay.
Yes.
क्या गिरीश लाल साहब सेक्रेटरी सर
तू किधर तू
नहीं इधर ही हूँ,
आजकल
बाजू में बैठा हूँ
तू आजकल दूज का चांद हो गया है हाँ
पहला चांद दूजा चांद
हाँ
पहला चांद इधर है दूजा चांद इधर है
हाँ फिर
नहीं नो ऑनलाइन चालू हो गया
Can we start?
Girish Lad, sir, okay. We'll start.
yes, yes, we can start. Okay, I'll start.
Share screen?
Yeah.
Just a moment.
Yeah.
We can start, sir.
Dr. Lad,
Yes.
ये क्या हो गया?
Yeah. Good afternoon, everybody. I, on behalf of Indian Medical Association Mumbai branch, welcome you all for today's webinar, Allergy and Asthma. See, we celebrated Asthma Day, World Asthma Day on 10th of May in Dharavi, that already explained in the previous webinar. And that was on last Sunday. That is on 15th. And on 15th also we had celebrated a webinar on asthma only. Today we are going to have allergy and asthma. That will include some other allergic topic as well. And this is under the guidance of Indian Medical Association headquarters. And that is why we are conducting it. Because usually we conduct on Sundays, but under the guidance of HQ, we are conducting it today. So I'm extremely happy that the speakers also, in spite of their busy schedule, they are joining, and even number of delegates joining is also very good. So with this, I wish you all a nice, knowledgeable CME today webinar, and I request our President, Dr. Anil Awad, to take over the proceedings and give his presidential address.
Yeah. Thank you, Dr. Girish Lad. Friends, today's lectures are in the continuation with the previous series which we had on allergic rhinitis. And today we are going to discuss about allergy and asthma. Since we started learning asthma, we knew it is initially we used to say that it is an allergic disease, and yes, there is something called as allergic asthma, and we have experts talking on this subject, so I will not say anything about the subject. I just here want to bring to your notice that there is another webinar coming on 29th of this month, and it's on the World No Tobacco Day. We have got 8 lectures, and we are going to get 2 credit points for the delegates who will attend the webinars. So do join in large number on 29th of May 2022. We have all expert speakers today. I mean, Dr. Harish Chafle does not require any introduction in IMA because he is like our family member. And Dr. Mitul Bhatt and Dr. Abhijit Ahuja, 2 young and dynamic speakers are there to talk today. Without wasting much of time, I request Dr. Jitesh Mehta, our immediate past president, to introduce our moderator for today's session, that is Dr. Harish Chafle.
Thank you, Dr. Awad. Friends, as you can see, Dr. Howard is working very hard. He has made a next CME program with 8 speakers and 2 credit points. So it requires a lot of hard work and coordination. I know all this, and he is doing it wonderfully well. Nevertheless, we shall start our program today, and it is with pleasure that I introduce Dr. Harish Chaple. He is a consultant interventionist, intensivist, chest physician, bronchoscopist, and sleep disorder specialist at Global Hospital, Parel, Mumbai. He did his DNB in respiratory medicine from the National Board of Examination, New Delhi, IDCCM from the Indian Society of Critical Care Medicine, DICC from Indo-Australian Critical Care Foundation, DTCD from Indira Gandhi Medical College, Nagpur. He has a vast experience in conventional bronchoscopies and bronchoscopic interventions. He has expertise in critical care pertaining to respiratory medicine with special emphasis on ventilators and non-invasive ventilators. He has several case presentations and publications in journals and conferences to his credit. He has written 2 chapters in the book PFT Made Easy by Dr. J.R. Shah. I request Dr. Harish Chaple to take over and moderate this session. Welcome, Dr. Harish Chaple.
Yeah, thank you. Thank you for those kind words of introduction. And thank you, IMA Mumbai branch, for holding this webinar and letting us speak about this topic. Any chest physician, for that matter, when it comes to speaking about his own subject, allergy and asthma is definitely one thing that we want to tell people why it happens, how it happens, and what care they need to be taken so that it does not progress to a serious stage. And annually, we keep on celebrating World Asthma Day, World COPD Day, just to make sure that the public is aware about all these diseases and disorders. They should know what it is, how the symptoms start, so that any disease, for that matter, once you come to involvement early in the part of the disease, you can control it better, and then the outcomes are definitely better. So with these words, I would just introduce initially the topic, and then we have 2 great speakers today to take the topic further, and then we will elaborate as per that. So just to introduce you all about allergic rhinitis and asthma. So I would be saying about allergic rhinitis, asthma differently, and UAD. That is called, you must be thinking this is upper airway disease, but not. This is not upper airway disease. This is a united airway disease. This is a link between AR and asthma. Evidence from epidemiology, pathophysiology, emerging biomarkers, and clinical. So allergic rhinitis, definitely I have seen many patients, they start the symptoms with allergic rhinitis, and if this is not controlled within time, not identified within time, and if the treatment is not taken adequately, then it progresses to allergic tendency and then subsequently to an asthma. So as we all know, it's an atopic disease characterized by symptoms of nasal congestion, rhinorrhea, sneezing, post-nasal drip, and nasal pruritus. And I have seen myself very commonly allergic rhinitis being associated with allergic conjunctivitis. That's when the patient gives history that whenever there is a runny nose or other things, the nose itches and simultaneously they have itching in the eyes. So they go hand in hand in many of the patients. It's an IgE mediated immune response, we all know, against inhaled antigens in the immediate phase and a subsequent leukotriene mediated late. So there is an immediate phase and a late phase. It affects 1 in 6 individuals associated with comorbidities, loss of productivity, and healthcare cost to them. So if you classify this into intermittent, persistent, mild, moderate, or severe, as either seasonal or perennial, as per the onset, basically intermittent or chronic, with approximately 20% of cases being seasonal and 40% being perennial, and 40% with features of both. In addition to nasal symptoms, patients with AR may also present with associated allergic conjunctivitis, as I was mentioning, non-productive cough, and eustachian tube dysfunction. We'll not go into details of the etiology, but we all know it's a Th2 mediated immune response that this initial response within 5 to 15 minutes of exposure leads to degranulation of the host mast cells, and then 4 to 6 hours later, interleukin 4 and interleukin 13 from mast cell they get secreted, and then there is development of late phase response wherein eosinophil T lymphocytes and basophils they accumulate in the nasal mucosa, produce nasal edema and resultant congestion. It's a non-IgE mediated hyperresponsiveness can develop due to eosinophilic infiltration at times in the mucosal layer. The prevalence of allergic rhinitis based on physician diagnosis is about 15%, and however, the prevalence is estimated to be as high as 30%. So that high is the prevalence, and it is very common in Mumbai, wherein we get seasonal variation. There is very high humidity as well as there is very high load of burden of chemicals in the air. So incidence of AR in pediatric population is also quite high and making it one of the most common chronic pediatric disorders. Seasonal allergic rhinitis seems to be more common in pediatric, whereas chronic rhinitis is more common in adults. If you see the comorbidities with allergic rhinitis, asthma, sinusitis, conjunctivitis, otitis media, pharyngitis, laryngitis, snoring is one of the important things which we need to identify in patients and diagnose OSA underlying if it is there, because I have seen patients of severe OSA, they presenting to the clinicians with uncontrolled diabetes, uncontrolled hypertension or ischemic heart disease or a stroke, but the underlying problem does not get solved. So that's how snoring is a very important symptom we should always ask these patients for. Then there are pharmacological options include antihistamines, internal steroids, we all know that. Coming to asthma in short, we know it's a common, non-communicable and variable chronic disorder which results in episodic or persistent respiratory symptoms or airflow limitation. If these symptoms are episodic and persistent, then we use shortness of breath, wheezing, chest tightness and cough. And airflow limitation happens because we know there is bronchoconstriction. And this bronchoconstriction leads to airway wall thickening, increased mucus production, and in the later part of the disease where asthma COPD overlap syndrome happens and chronic changes of asthma happens, these muscularis mucosa inside, this muscle, they get hypertrophied, and that is how it becomes an irreversible obstruction in that phase. The pathophysiology involves various host environment interactions occurring at various scales from genes to organs. We are coming to know about epidemiology pattern as well as the pathophysiology of a lot of disorders which we studied initially in your MBBS days in a depth now. That's how I think United Airway Disease is the term coming. Respiratory tract is considered as single entity now. It's not upper airway or a lower airway, both morphologically as well as functionally. And these are strong evidence supporting an integrated view of AR and asthma in United Airway Disease. So this is epidemiological evidence. AR, 19 to 38% of patients, and asthma have AR being 30 to 80%. That's high the incidence is. And the prevalence of asthma in patients without rhinitis is usually less than 2%. So without rhinitis, it is very uncommon, but with rhinitis, it's very, very common. This is the link which I was talking about. Communication between the upper and lower airway suggests to be via bone marrow derived systemic inflammatory response. That's how both gets involved. And the hallmark of the presence of epithelial basement membrane thickening, the typical hallmark of lower airway remodeling, seen in asthmatic patients, in atopic patients without asthma and patients with AR. In non-allergic asthma, it has been highlighted the importance of the presence of IgE in the bronchial mucosa as in nasal mucosa in local allergic rhinitis. And these are the emerging biomarkers where there is role of microbiome. Children being raised on traditional farms have a much lower prevalence. There was a big study, and those who were raised in the traditional farms with exposure to dust in the early part of their life, they were at less risk of developing asthma than the children who were raised in environment where there was very clean environment, no exposure to dust or dirt, and that is how later part of their life they develop uncontrolled asthma. Presence of same particular miRNAs in different pathogenetic mechanisms of both AR and asthma, such as IL-13 pathway, GATA binding protein 3, and mucin secretion. So there is a clinical evidence. Treatment of AR can improve asthma symptoms. So if you treat AR adequately, asthma symptoms automatically improve, or vice versa. If you don't treat AR, asthma will not improve so much. So beneficial to the lower airway, reducing the symptoms, reduces the emergence of room visits or emergency visits in the hospital, reduces the incidence of hospitalization, and severity of bronchial hyperresponsiveness gets reduced. Offers preventive effect on asthma development in allergic rhinitis and children undergoing therapy. And if you see 3.8-fold more frequent development of asthma in untreated patients, that's the massive number, 3.8-fold, 3.8 times. These are the risk factors we all know for asthma. History of allergic rhinitis, again, the biggest risk factor I would say. Age of the patient, people exposed to outdoor environment, males are more likely to be affected, Asian or Indian ethnicity. A pre-existing diagnosis of asthma is highly likely for individuals who suffer from severe thunderstorm-related intensive care unit admissions or death. I'll not go to the management part because our speakers are going to speak. Novel aspects in management of upper airway, United Airway Disease, basically. Bronchial thermoplasty is one of the indicators where if you think that it's irreversible airflow obstruction, there is a hypertrophy of the muscular layer in the bronchi, then you can reach with the help of a bronchoscope, and then with the bronchial thermoplasty, you can literally burn that hypertrophied muscle, and that is how the irreversible obstruction can be relieved. So then there is novel aspect in the management of, so telemanagement refers to helping an individual patient on the ongoing management by employing information and communication technology, which was the main focus of treatment during the COVID era. We know that we all treated patients online, and this is definitely a novel aspect in the management of United Airway disease. So it includes technologies and tools that can be used to communicate, gather, and store data by electronic means. So I end with these words, and I hand over to the next speaker for the further presentation.
Thank you very much, Dr. Chafle sir. And before we go on to the next speaker, I request Dr. Kajal Ahuja to introduce the first speaker, that is Abhijit Ahuja.
Good afternoon. Dr. Abhijit Ahuja is consultant pulmonologist at Saifi, Bhatia, Zen, and Shushrat hospitals. He did his MBBS and MD in pulmonary medicine from D.Y. Patil Medical College, Navi Mumbai. He has completed his fellowship in interventional pulmonology and thoracic oncology from Rajiv Gandhi Cancer Institute, New Delhi. He received EDRM, European Diploma in Respiratory Medicine from European Respiratory Society, Milan, Italy. He did observership in interventional pulmonology at Tan Kok Sang Hospital, Singapore. He received Young Researcher Award at BronchoCon 2018, Coimbatore. He expertises in bronchoscopic interventions like balloon dilatation, airway stenting, and EBUS, that is endobronchial ultrasound bronchoscopy. He has numerous publications in various national and international journals on interventional pulmonology, respiratory disease, and thoracic oncology. Today, he'll be speaking on a pulmonologist's approach to manage allergic rhinitis. Over to Dr. Abhijit Ahuja.
Thank you for the kind words, ma'am. And good afternoon, everyone. Just want to share my screen. I hope my slides are visible.
Yes, yes.
Yeah.
Thank you, Dr. Chafle, Dr. Awad, IMA Mumbai, Dr. Ladd. Today, I'll be taking you through managing allergic rhinitis, an approach that we pulmonologists usually take. As Dr. Chafle has already taken us through very nicely to both the diseases, that is allergic rhinitis and asthma, I'd be trying to connect the two and also speak a bit about managing allergic rhinitis. So there's a high prevalence of allergic rhinitis among Indians. Various studies have shown.
Can you go to a bigger slide? I mean, the slide one.
Sorry, sir.
Full screen.
Can you just screen? Can you go to slideshow?
Yeah, I'll just do that.
Yes.
Yeah.
Okay. Yeah.
As I was going through, the prevalence of allergic rhinitis among Indians remains high. Globally also, it is a common atopic condition, allergic rhinitis, that affects about 10 to 30% of adults up to even 40% of children. It often is got an early onset in life and around 11% in children around 6 to 7 years old and goes up to 24% in children aged 13 to 14 years. In India, almost 20 to 30% of the population is suffering from allergies and allergic rhinitis. Looking at coexistence of the disease, basically this study done by Dr. Alpadalal and Jaggi V showed that 65% of asthmatic patients have coexisting allergic rhinitis. History of atopy, passive smoking, exposure to biomass fuel, presence of pets at home is also a link for coexistence of allergic rhinitis and asthma. The prevalence was found to increase with increasing in the asthma severity. So if you have got a patient who's an asthmatic not doing well, you would want to even ponder on these things such as the ones which are exacerbating the allergic rhinitis too. This study done by S. Monga showed that underlying asthma in patients with allergic rhinitis is also a big incidence. They had done a study in around 70 patients in which they looked at doing pulmonary function tests in patients with allergic rhinitis, and most of them had a mild obstructive disease, or some even had moderate. The breakup of allergic rhinitis causes and the presence was also seen, where you had comorbid latent asthma in certain patients, especially with intermittent allergic rhinitis. The ones which are responding well to your treatment had a larger amount of asthma present in them. So one must also think both the diseases are related. It's a unified airway, as Dr. Chafle rightly put it, and we must look for both the diseases if you have presence of one. Now, this study done in the Philippines basically looked at what are the attitudes and practices of treating allergic rhinitis between a general physician, such as a family physician, and specialists. So it was a cross-sectional survey of around 100 specialists and 100 generalists. Adherence to guidelines on allergic rhinitis was more seen with the specialists, and the guideline followed was morely the ARIA guidelines, which has been actually put together by WHO and has been revised with time. And other guidelines were also followed by certain generalists compared to specialists who stuck to ARIA guidelines. The devices routinely used by pulmonologists for diagnosis and monitoring of this disease was pulmonary function test, peaks, expiratory flow meters, plethysmography, carbon monoxide diffusion or DLCO, pheno, bronchoscopy, and sputum assessment. Devices aimed at allergen avoidance were morely breathing masks, and devices for mobile health included devices for self-assessment and treatment assessment. In management of mild allergic rhinitis, monotherapy with antihistamines was the first line of treatment, followed by both. If you look here, most of the doctors in the entire study followed this, whereas in moderate to severe, the preference for monotherapy versus combination remained similar. There was not a lot of difference between both of them, the specialists as well as the family physicians, and both preferred anti-leukotrienes, antihistamines, and intranasal corticosteroids. The preferred duration was also similar. So basically what you see is that both of them are using monotherapy for a week or even a combination for a week. And for moderate to severe, you would want to look at a month's treatment of the intranasal sprays and a week to 2 weeks of the oral medications that are prescribed. Now, what would be the approach which would be different between both for management was also seen with another study in which they said they looked at 50% of all physicians of all specialties were giving this sort of a allergen reduced diet to pregnant and lactating women and avoiding pets at home. This was actually not recommended by the ARIA guidelines. It was a conditional recommendation. However, it was being followed by most of them. So ideally, one should not be giving this advice out as it is not found to be beneficial. Secondary prevention of IgG-mediated respiratory allergies. The treatment of allergic rhinitis without asthma, antihistamines was the way to go. Most of the pulmonologists use newer oral antihistamines over old. So that would mean generation 2 or generation 3, which was more preferred by the first generation ones. Treatment of severe allergies without asthma, glucocorticoids, we could have actually the ARIA guidelines do suggest if you're looking at severe allergic rhinitis, it is the way to go. Whether given intranasally is actually what is preferred. Oral glucocorticoids is a fine line, usually left to the specialist. Here also 96% of the pulmonologists suggested using intranasal glucocorticoids. And a meta-analysis showed that monotherapy with an antihistamine or LTRAs like montelukast has low to moderate efficacy in treatment of seasonal allergic rhinitis, but both are less effective than intranasal glucocorticoids. So basically, if you know that the patient is progressing or has progressed to a severe allergic rhinitis, intranasal steroid is the way to go, along with oral LTRAs or oral antihistamines, not monotherapy of either. In this study, we looked at a third of the pulmonologists preferring intranasal antihistamines over intranasal chromones. Cromolyn sodium is not actually available in most of the markets worldwide. Hence, intranasal antihistamines like azilastine were preferred. And oral H1 antihistamine alone versus in combination with a decongestant, most of them preferred a combination itself, as an oral antihistamine alone would not probably give you a greater control over the patient's symptoms. For patients with more severe disease, decongestion should be used in shorter cycles. They are not found to be of greater value over intranasal glucocorticoids. A pan-India study, this was a pan-India study done in late 2020, which was published, in which they found that oral H1 antihistamines were favored by 52% of physicians, which included pulmonologists, as a first-line therapy, followed by a combination of oral H1 antagonist and a montelukast. Of the combination treatment, the majority physicians favored a combination with LTRA, followed by a combination of oral antihistamine with decongestant. And fexofenadine was the most preferred antihistamine in the study. Pharmacotherapy in patients with treatment or with the patients of allergic rhinitis with concomitant diseases, third generation antihistamine and nasal corticosteroids were the most common drugs in management of allergic rhinitis as well as concomitant hypertension. Similarly, for even type 2 diabetes and also in other cardiovascular diseases, the third generation antihistamine was always preferred over the others, along with the combination with nasal corticosteroids. And it was also found to have better control and lesser side effects. There were no side effects actually seen. Similarly, allergic rhinitis and concomitant sleep apnea, which is also actually forms a large number of patients. The numbers are quite large in these two diseases coexisting. Basically, third generation antihistamine was most commonly used along with nasal glucocorticoids. So most of them are following the guidelines and probably are at a good in viewpoint in which they are combining the intranasal glucocorticoids as well as oral antihistamines with or without LDRAs. This is a very good flowchart that would actually guide us as to how to go about managing a patient of AR. After diagnosis, one must investigate the presence of asthma, especially in patients with severe or persistent rhinitis. If they have intermittent symptoms and if they are mild, you can use either an oral or intranasal antihistamine or add a decongestant or use a leukotriene receptor antagonist. In moderate or to severe, in which the symptoms remain intermittent, you can use the oral therapies as mentioned. Plus, if you want, you can add a fluticasone and azilastine in the intranasal combination. This gives you a better, as soon as the patient moves into a moderate and you know that he's at a moderate AR, it would give you a better control over the disease. You look at a persistent rhinitis, you look at the patient after 2 to 4 weeks. There's a treatment failure, you'll upstep into the severe range. If he's responding, you continue on the same line. Similarly, in patients with persistent symptoms, you would look at them being, if they are moderate to severe, the preference would be fluticasone and azilastine in intranasal combinations, or intranasal corticosteroids with oral antihistamine is also a good combination to try. On follow-up, if the patient is improved, you can go down a step, probably try and withdraw the intranasal antihistamine and continue the orals or vice versa. If there's no improvement, you need to review and go back. Think about compliance, because this is the biggest thing. Intranasal corticosteroids give you symptom relief very quickly, and your patients will ought to stop using the therapy and actually tell you that actually they've been using it. But if you go about needling into their history, you would come to know that they have stopped using their nasal sprays much before you have actually prescribed. If you look at other causes, looking at infections that are actually compounding the problem, you can add or increase the dose of intranasal steroids if you feel there's not enough control. If there's an infection, you can try with the antibiotic. If there's rhinorrhea, you can add ipratropium. Mind you, ipratropium nasal sprays are hard to come by. So you can use an ipratropium inhaler and actually tell them to puff. If there's an obstruction, you can add a decongestant and an oral corticosteroid of a shorter course, because sometimes these resistant severe allergic rhinitis do require this. In case of failure, you refer to a specialist, preferably an ENT, so that they can have a look if there's some physical obstruction or there are other compounding issues like nasal polyposis. Avoidance of allergens and irritants should be advised to any patient, and adding an oral antihistamine or intraocular antihistamine or a chromone is especially helpful in patients which are having a lot of ocular symptoms. And specific immunotherapy, which I'll be coming down to, is very useful in patients with moderate to severe, especially recommended in patients with severe allergic rhinitis. The ARIA guidelines, the last time they were reviewed was 2019. This is the flowchart that they wanted us to follow, in which you look at a visual acuity scale of the patient presenting with allergy. If the scale is below 5, a patient that means is falling into the mild category, you would start with first line medication. That would include an antihistamine or an intranasal corticosteroid or a montelukast or a combination of the two. That is an intranasal corticosteroid with azilastine. You reassess daily up to say 2 to 3 days. If he continues to remain in the lower range of the VAS score, you can continue treatment. And if he's not symptomatic, you feel he's getting better, you can start to step down or even stop the treatment. However, if you feel the patient is moderate or above, that is a VAS score is quite high, and intermittent rhinitis, you can start with any suitable therapy from the first line. If it is still persistent, you can add intranasal therapies, that is corticosteroids or antihistamines. Similarly, if the patient continues to remain quite symptomatic, you have to step up and reassess. Now, again, if you are looking at a reassessment and the patient is not responding, continues to remain in the same symptomatically, as well as, or if he's getting worse, then you would want to refer to an allergologist and look at immunotherapy. The step-up algorithm in patients who have already been started on treatment, the fixed combination of intranasal corticosteroids and azilastine is more effective than a monotherapy, and especially in patients where it was earlier offered as a monotherapy and it was inadequate, or for patients who are severe allergic rhinitis or are not getting quick relief from their symptoms. So what you can do is basically add the, if you want, you can start off with a single monotherapy and then go gradually up titrate using the combination, or start off with the combination to begin with, as we discussed in the previous chart, where you know that the VAS score is high, and keep reassessing and then try to downstage. This is a difficult disease. Actually, usually patients present with resistance to the therapies that you're giving. Severe chronic upper airway disease in patients which is actually a disease in which patients are inadequately controlled despite adequate pharmacological treatment. And it's about, the number is small, but it is there. It's 6.8% in allergic rhinitis patients and higher in polysensibilized patients, that is in patients which have got a greater inflammation, like we see in severe asthmatics. And the guidelines recommend using allergy immunotherapy for moderate to severe allergic rhinitis. Despite the recommendation, only 20% of such patients are actually prescribed. So one must always keep in mind the immunotherapy as a last option for patients who are progressing despite adequate treatment. Fexofenadine is a preferred antihistamine for management of allergic rhinitis. It's a new generation antihistamine, highly selective, has positive antihistamine effects. It has no cardiotoxicity, minimal adverse effects on the liver, and is also found to be safe in the elderly cohort. It has significantly lower adverse events frequency, sedative effects frequency, and less change of cognitive psychomotor function versus first generation antihistamines. It also has significantly less change of most of the cognitive and psychomotor function versus second generation. So patients will not feel drowsy. They'll be confident to continue working, driving, and in fact, even your patients with having the elderly subcohort having cognitive psychomotor issues will also not have any issue with the fexofenadine. The combination of montelukast with fexofenadine helps in reducing symptoms of allergic rhinitis that are not controlled with antihistamines alone. Also, especially with patients who have got nighttime symptoms. It is montelukast as monotherapy has significantly better improvement in nighttime symptoms versus antihistamines if you look at only nighttime symptoms alone. And the combination could provide enhancing and complementary effects, reducing both daytime as well as nighttime symptoms. So we have evidence that suggests that in patients with allergic rhinitis, mean change in total nasal symptom score is significant with montelukast fexofenadine compared with montelukast levocetirizine. Now, looking at the efficacy of the combination, this was a head-to-head trial done to see the efficacy between montelukast and levocetirizine versus montelukast and fexofenadine. Patients recruited were from the age of 18 to 65, having moderate to severe, intermittent or mildly persistent allergic rhinitis. And the parameters were for the total nasal symptom score was the main effectiveness parameter. The results of this study was a blinded study in which they found that there was a significant change in montelukast fexofenadine group. So patients were getting better with the newer generation of antihistamines. Significantly greater control over the symptoms. You can see here that even in 1 week of treatment with montelukast fexofenadine group here, it has shown a mildly better improvement, and especially in day 14, it shows a much greater improvement. Similarly, in total ocular symptoms also, similar benefits were seen. And it has got less incidence of sedation. So patients you're actually going about doing their day-to-day activities much easier. Fexofenadine the combination is more effective than individual therapies alone. This trial actually looked at daily scores of rhinitis. The patients were made to maintain a daily diary card that was an average of nasal congestion, itching, sneezing, and rhinorrhea. And we were grading it from 0, 1 to 3. 3 would be the lowest, and 0 would be the most severe. And the comparison of the VAS satisfaction scores. So group 1 was fexofenadine alone. Fexofenadine montelukast was in group 2, and fexofenadine with placebo was given in group 3. If you look at all these daily diary scores, they are almost the same from 0 to 3. However, as you look at day 15, 2 weeks into treatment, the best diary scores were seen with the montelukast and fexofenadine as compared to the other two groups, especially with the VAS satisfaction also. The scores were higher in the group with montelukast and fexofenadine. The SKY study actually looked at latest molecule to come into the market, that is bilastine with montelukast, and did not actually find consistent symptomatic improvements over 4 weeks beyond those provided by either agent alone. So there was not much of a benefit seen with the bilastine plus montelukast combination to provide a relief of these symptoms in partially controlled mild to moderate asthma patients. Comparison of available corticosteroids, fluticasone furoate compared to all the other corticosteroids available scored the highest in terms of all the values. So bioavailability was good, protein bindings was excellent, half-life was the maximum amongst all, as well as the the relative receptor affinity was the highest. So fluticasone furoate was actually found to be the leader amongst all these other intranasal corticosteroids which are available in the market. So this molecule, fluticasone furoate, has become a corticosteroid of choice. It has enhanced affinity, low systemic bioavailability, onset of symptom relief as early as 8 hours, and 24-hour symptom relief with one daily dosing, comprehensive coverage of both nasal as well as ocular symptoms. It's safe and tolerable with daily use, and potential to enhance patient satisfaction and compliance is seen. To round it off, monotherapy with new oral antihistamines is the preferred first line of treatment for managing allergic rhinitis. This helps you upstage and even add many more medications as the patient progresses, if he does. Of the combination treatment, Indian specialists favored combination of an oral H1 antihistamine with LTRA. However, the third generation antihistamines were the best, as we could see in the various studies that I've put forward. And intranasal corticosteroids, along with the third generation antihistamines, were preferred for the management of allergic rhinitis and concomitant diseases. With this, I would thank you for a patient listening and hope that my talk has put a good enough of light upon management of allergic rhinitis. And I would like to now give my mic to Dr. Mitul to take us through the next lecture. Thank you.
Thank you very much, Dr. Abhijit. We'll have question and answer session at the end. Will that do?
I think that would be the way to go. We can take it all together, keep it open to the house.
At the end of the session.
Yes, sir.
Okay. Thanks a lot. And we move on to the next speaker, that is Dr. Mitul Bhatt. I request Dr. Kashyap Dakshini, the Assistant Secretary, IMA CGP Mumbai Sub-Faculty, to introduce Dr. Mitul. Just a moment, I'll just share his
Good afternoon, friends. Dr. Mitul Chaitan Bhatt is a young, dynamic ENT and head and neck surgeon practicing in Mumbai. After passing MBBS from MUHS, he did his MS in ENT from SMF Miraj, followed by DNB ENT from Delhi University. Dr. Bhatt received vast experience in the field of ENT while working in Seth AJB Municipal ENT Hospital, Fort and Bhagwati Hospital, Mumbai, the two most premier institutes for ENT training in Mumbai. Dr. Bhatt has also a fellowship in otorhinolaryngology and cochlear implant surgery under Dr. M.B. Kirtani. Dr. Mitul Bhatt also has an international fellowship in rhinoplasty and cosmetic nasal surgery from Germany under world-renowned plastic surgeon, Professor Dr. W. Gubish. Dr. Bhatt has publications in various national and international journals. Today, he will speak on key conference updates, respiratory allergies, and asthma. Over to Dr. Mitul Bhatt.
Thank you. Thank you for the kind introduction. And I'll just start sharing my screen. Okay, is my screen visible?
Yes.
yes.
Okay, so at the outset, I'd like to thank IMA for inviting me for this talk. My topic for today is key updates from the various conferences across the globe with regards to respiratory allergies and asthma. So, hello, I am Dr. Mitul Bhatt, the consultant ENT surgeon, and these are my affiliations. So, what are allergies? So, the term allergy is used to describe an overreaction to substances in the environment that are harmless for most people, but induce an immune response that cause a variety of symptoms in predisposed people. There are various types of allergies and symptoms, the most common being the respiratory allergies, such as allergic rhinoconjunctivitis, allergic asthma, which causes wheezing, coughing, shortness of breath, sneezing, running nose, sinus problems, and also red, watery, or itchy eyes. The second is skin allergies, such as atopic dermatitis, also known as eczema, and contact dermatitis, which results mainly in a skin rash. The other allergies include food allergies or allergies to insect venom, which cause different types of reactions, which in some cases may even be life-threatening. Yeah, respiratory allergies.
Dr. Mithul, you're on mute.
Yeah, is my screen visible? I think I lost connectivity for a minute.
Yeah, now it's visible.
Okay. So allergic rhinitis is a common and distressing inflammatory condition affecting the upper airways and the membranes of the nose and eyes, causing an allergic reaction to any allergen. Allergic rhinitis affects 5 to 50% of the population worldwide, among which 15 to 20 suffer from a severe form of the disease. Allergic rhinitis is considered as a significant risk factor for allergic asthma. Now, what is asthma? So asthma is a chronic inflammatory respiratory disease characterized by reversible narrowing and hyperresponsiveness of the bronchial airway to a variety of biological and environmental stimuli, with classic symptoms including wheeze, recurrent cough, and dyspnea. Today, more than 339 million people have asthma globally. Asthma coexists with rhinitis and is an important cause of chronic morbidity and mortality all over the world. The allergic march, so from allergic rhinitis to asthma. As we discussed, allergic rhinitis is a very important risk factor for asthma. Patients with allergic rhinitis have a 3 times greater chance of developing asthma. The mechanism of allergic rhinitis leading to allergic reaction leading to allergic rhinitis and asthma is shown in this figure. So basically, when your system comes in contact with the allergen, it results in activation of 2 types of cells. First is the mast cell, which release mediators such as histamine and leukotrienes. These are responsible for acute symptoms such as sneezing, spasm of the airways, itching, rash, tissue swelling. The others are the T2 helper cells, which release cytokines and chemokines. These, along with leukotrienes, result in prolonged symptoms such as airway narrowing and swelling, breathlessness, and wheeze. Complications related to allergic rhinitis and asthma. A blocked or runny nose can result in difficulty sleeping, drowsiness during the daytime, irritability, and problems concentrating. It will also make asthma symptoms worse. Inflammation associated with allergic rhinitis can lead to other conditions such as nasal polyposis, sinusitis, or middle ear infections such as serous otitis media or acute or chronic otitis media. Asthma, poorly controlled asthma has a negative impact on the quality of life, such as there is fatigue, exhaustion, poor sleep cycle, reduced lung function, poor mental health as well, being less productive at work or while studying, inability to exercise or be physically proactive, more emergency room visits, and prolonged hospitalizations. Also, there are certain side effects for the long-term use of certain medications which are used to stabilize severe asthma. Now, at conferences and scientific meetings, what do we commonly discuss? First is various essential issues faced by doctors who treat such patients. Second is the risk factors, modes of diagnosis and exploration in children as well as adults, and their specific treatments. Also, the idea is to help practitioners in distinguishing what is established from what remains to be demonstrated, with respect to different modalities with regards to treatment and diagnosis. Now, this is the list of conferences from which I will be discussing the abstracts in my subsequent slides. The European Academy of Allergy and Clinical Immunology, American Thoracic Society International Conference, 13th International Conference on Allergy and Immunology, International Conference on Asthma and Allergy, and International Conference on Lung Diseases. Yeah, coming to the first abstracts. So early life wheeze is an important risk factor for asthma by the age of 7. 156 children along with age-matched healthy controls were studied. The protocols included questionnaires, exhaled nitric oxide, blood sampling for cell count, IG, etc. They were first followed for 2-3 months and thereafter annually till the age of 7. It was seen that 69.9% of acute wheeze patients had asthma as compared to 1.9% of the healthy controls. Also, they had to be hospitalized more often. So this study also concluded that rhinovirus has a great impact on asthma development. The second study is comparing the relative risk and prevalence of pneumonia and asthma in children with preterm birth. As you can see from this chart, the more preterm the baby, the higher the risk of developing pneumonia and asthma at a later age. Third study was to determine the effect of high pasteurized milk or sterilized infant formulas and the risk of asthma. These children were assessed at the age of 5. Food records were completed first at the age of 3 months and 6 months, and then annually for the first 4 years. The outcomes were studied at the age of 7. 6% participants had asthma. It was seen that consumption of milk-based infant formulas increased the risk for asthma by 9%, whereas high pasteurized or sterilized milk and milk products increased the risk by 4%. Now, studying the occupation hygiene factors triggering asthma. So if you can see in this chart, the various factors with regards to occupational hygiene which were studied were low air temperature, high relative humidity, increased carbon dioxide concentration, presence of mold, and the age of children. So it was seen from this study that there is an increased relative as well as an absolute risk to developing bronchial asthma when these factors are considered. Yeah. An important and often overlooked finding is mental health in patients who are diagnosed with asthma. So this study showed that patients who were diagnosed with asthma at an early age, in this study, the mean age for diagnosis was 3.8 years, had 24.4% of those children had a mental health condition, of which 10.8 had anxiety, 8.2 had attention deficit hyperactivity disorder, and 5% had depression as well. Coming to the next study, central obesity was associated with asthma and asthma severity, but not with atopy. Relationship between anthropometric measurements, asthma, atopy, obesity, and each other was analyzed. These are the outcomes. Obesity, according to BMI, was more common in the allergic asthma group versus the non-allergic asthma group or the control group. Central obesity, according to waist circumference, was found to be higher in the allergic and non-allergic asthma groups as compared to the control group. It was also seen that 34.6% of the children were normally weighted according to the BMI, but were defined as obese according to the waist circumference. So in children with asthma, waist and hip circumference should also be measured in addition to height and body weight, BMI and waist hip ratio. Classroom-based air pollution increases airflow obstruction. This study was done with comparing the increased risk of asthma with certain air pollutants such as classroom nitrogen dioxide, fine particulate matter, and black carbon for 1 week periods. The outcome shows that for each 0.1 microgram per cubic meter classroom, black carbon was associated with a 30% higher chance of having symptoms in that day. And history of preterm birth was associated with greater asthma symptoms. Particulate matter was associated with significantly lower forced expiratory volume, and more so in premature children. So a history of preterm birth is associated with lower lung function with exposure to indoor fine particle solution. The next study is lung function decline gradually in early onset childhood asthma. 171 asthma patients' lung function data was reviewed. 6.1 had declined forced expiratory volume values more than 5%. Trajectories of lung function in the non-decline group appeared that FEV1, that is the forced expiratory one, increased from 6 years of age when initial lung function tests were performed until early teenage and plateaued and then gradually declined in the 20s. Forced expiratory volume in the decline group started to decline from the 10s, especially declining small airway parameters was quite significant. Yeah. Next study is fruit and vegetable intervention to improve lung function. So it was seen that patients who had a higher fruit and vegetable diet group had significantly lesser subjects who experienced 2 or more asthma exacerbations. Lung function improved in the high FNV group, indicated by a decrease in airway resistance and increase in airway reactance. In the low fruit and vegetable group, plasma CRPs were raised, GRP41 gene expression was decreased, and HAD enzyme activity was increased. The next study is daily exercise could have a beneficial effect on asthma in children. So 110 children with mild to moderate persistent asthma was studied. Follow-up was after 2 weeks. FeNO was measured. So after 2 weeks, there was a significant decline in the FeNO levels, highlighting the improvement in airway inflammation. Also, improvement of running distance was seen, suggesting improved exercise capacity even in short periods of time. Sublingual immunotherapy helps achieve control of disease and decrease in volume of therapy for allergic rhinitis and allergic asthma in children and adults. So a sublingual immunotherapy was done and evaluated in these patients. These are various scoring systems which are used. The first is the combined symptom and medication score in children with allergic rhinitis was 4.33. After 1 year of sublingual immunotherapy, the score was 2, and after 5 years, it was 0. In adults, also, the results were quite similar. The initial score of CARAT 10, which was control of allergic rhinitis and asthma test, was 20.5 in children with allergic asthma and allergic rhinitis. After 1 year of sublingual therapy, it was 28, and after 5 years, 20. Also, the levels of certain inflammatory markers such as cytokines, interleukins, TGF beta, etc., had shown improvement. Immunotherapy with microcrystalline tyrosine associated mites allegroid reduces severity of disease. So it was seen in patient 306 children, adults and adolescents with dust mite induced allergic rhinitis with or without asthma were treated with allergen immunotherapy with different treatment regimens of a glutaraldehyde modified MCT associated extract of mites. These showed significant clinical improvement comparing them with analyzed variables 12 months before the initiation of therapy and after. According to the JAMA classification, the percentage of patients with moderate severe persistent asthma changed from 46.9 before therapy to 5.6 after therapy, and 32.5 had no symptoms after the treatment, and the use of medication to treat asthma changed before and after. Yeah. Probiotic microorganism Lactobacillus reuteri in early child's diet prevents allergic rhinitis. So 316 maturely born infants with a positive history of parental allergy were divided into 2 groups. Group A, which was exclusively breastfed for 4 to 6 months, and Group B, which was breastfed with addition of Lactobacillus reuteri from 4th week of life for 12 weeks. So the outcomes were that at the age of 9 years, the prevalence of allergic rhinitis in the total population was 19.6%. The prevalence of allergic rhinitis was significantly lower in the B group, That is the group which was given lactobacillus in addition to breastfeeding. Also, the frequency and duration of exacerbations was much lower. Now, severity of allergic rhinitis in relation to asthma control. In 35 severe asthma patients, control of allergic rhinitis were evaluated using the control of allergic rhinitis and asthma test questionnaire. The outcomes were that up to 74% of the patients felt that their asthma is always worse when they are symptomatic with allergic rhinitis. Comparing the allergic rhinitis and asthma scores separately in the CARET scoring, allergic rhinitis control is slightly worse as compared to their asthma control. Now, these are a few snippets from certain conferences over the world. So this is a study where a 3-year follow-up of the 2016 Melbourne epidemic thunderstorm asthma patients was conducted. It was seen that even after 3 years, high proportion of patients continue to have asthma symptoms. Only 41% of the patients reported compliance of more than 5 days per week, and 30% did not use their preventive medication at all. So we conclude that there is a need for improved asthma planning and education for long-term symptom control. This is another study which says that stress increases the risk of allergic asthma. These were the findings of that study, that 98 out of 133 asthma patients experienced a stressful life event during the 6-month period before the onset of symptoms. There is significant correlation between the experience of a stressful life event and the onset of asthma. A very strong linear correlation between a precedent stressful life event and higher than 3+ perceived general stress score. So, strategies of stress management might enhance prevention and ameliorate allergic asthma control. Yeah. This is a study taking into account fexofenadine versus placebo for seasonal allergic rhinitis aggravated in the presence of air pollutants. This was a phase 3 double-blinded randomized study. Single-center study was performed using environmental exposure unit in 3 sequential exposure periods. The first one was with ragweed pollen alone. The second one was ragweed pollen plus diesel exhaust particle, and the third one again was with RP plus DEP. To evaluate the effect of exposure of 251 allergic rhinitis subjects who were assessed symptoms over 12 hours. During the period, subjects were randomized to receive fexofenadine hydrochloride 180 milligrams or a placebo. So the primary outcome was that the total nasal symptom score significantly higher in period 2 than period 1. These indicate an aggravation of allergic symptoms in presence of diesel exhaust particulate. Now, the total nasal symptom score was significantly lower in the fexofenadine group as compared to the placebo group, as seen from this chart, which indicates that fexofenadine is effective in reducing symptoms of AR. The nasal symptom score was the sum total of the rhinorrhea, nasal itching, and sneezing scores. The secondary outcome was that individual symptom scores were lower in the fexofenadine group compared to the placebo group. Frequency of treatment emergent AE was comparable between fexofenadine and placebo. So to conclude, allergic symptoms are aggravated by diesel exhaust particulate, and that fexofenadine hydrochloride 180 mg is effective and well tolerated in subjects suffering from allergic rhinitis, with symptoms aggravated in the presence of diesel exhaust particulate. So coming to the conclusion, increase in incidence, prevalence, and morbidity of respiratory allergies presents a significant challenge to public health. Insights from evidences presented in the international and national conferences will support future research on all aspects of respiratory diseases. Participation in conferences facilitates knowledge exchange amongst clinicians, since it provides a platform to discuss practical clinical challenges and their solutions. The conferences discussed offer new insights on respiratory diseases and their management. Thank you.
Thank you very much, Dr. Mitul. It was really an exciting session. Is there Dr. Harish Chafle is there? Chafle, sir?
Yes, Bola.
Any comments from your side?
Yeah, so Mitul has definitely very nicely compiled whatever has been done in recent publications as far as risk factors, prevalence, as well as management was concerned. Actually, it's a very good habit to compile all things together, because the listeners, the viewers, the ones who have joined this webinar can come to know at a nutshell what has happened recently and what is the takeaway from that, which can be implemented in the practice, so that the patient outcomes as well as our understanding of the disease also improves. So I think, yeah, Mithul, well done, very nicely, in a very short manner you explained that. And we go to the questions, if any.
Yeah,
From
there's
the
only one question in the question box. What is the durability of immunotherapy in treatment of allergic rhinitis and associated pulmonary diseases?
So Mithul or Abhijit, who wants to take this?
Can I take this question?
Yes.
Yeah, Mithul.
Yeah, sure.
So the duration, the durability. So two things. First, let's start with the allergy test. So there are different types of allergy tests also. One which is routinely performed is the skin prick allergy test. The other is the blood sampling. Now the skin prick allergy test gives us tells us exactly what substance you're allergic to, say food, dust mites, pollens, pigeon droppings, etc. From that, whatever is avoidable, yes, certain food items you can avoid in your diet, just try and avoid that. Those which you cannot, okay, then for that, there is a specific immunotherapy directed specifically towards that antigen. So the duration of that treatment is quite long. I mean, there is a problem with compliance sometimes. So generally, I start the patient on, say, about 2 or 3 allergens, which he is the most strongly allergic to. And that therapy goes on for, say, about 6 months to a year. And based on the improvement in symptoms, we may consider giving a booster and otherwise tapering off the therapy. The second is the blood allergen testing. It is more comprehensive or exhaustive, I would say, because it not only tells you what allergen, but what component of the allergen is your body is most sensitive to. For example, if it was milk, so you may not be allergic to everything in milk. It may just be casein or something else. So yeah, there are definite advantages of allergen immunotherapy, but the compliance is still a bit of an issue, and the acceptance is also a bit of an issue because people want quick results.
Thank you, Dr. Mithul. There's another question. What about sodium chromoglycate? Why it has disappeared?
Because there are more effective and better solutions available in the pharma world right
now. Would increasing probiotics in diet help in both AR and asthma?
Definitely. I mean, sorry, if anybody else would like to take the question, Abhijit or sir.
No, that's fine. I think you hit the point anyway. It would help, especially if you're looking at the childhood rhinitis or childhood asthma. And in general, studies have also shown that probiotics are helping in more than one issues with regards to your allergies. So yeah, I think yes.
And one more thing I just wanted to ask you, what about this injection histoglobin? Are they useful?
So personally,
yeah, Mithul, go ahead.
Yeah, sorry. Personally, I have no experience in injectable histoglobulin. So, I mean, sir would be a better person to take this question.
Yeah, particularly histoglobulin is an injection available, which is I have seen many people started using it. This is useful only for patients who have a very chronic urticaria type of presentation, a skin itchiness, and all those skin manifestation of allergic disease in the form of urticaria and atopy. So these patients, which they keep on requiring oral steroids from now and then frequently, because taking oral steroids for long is, we all know what are the side effects. We all have gone through steroid being overused and misused in this COVID era, and we know what can happen with steroids. So if somebody is requiring it more frequently and they are not able to prevent the exposure to something which is causing this repeatedly, and they are not able to identify also, I think histoglobulin is an option available now, and I had used in few patients with a very good result, but I would say no, I don't have much experience to tell you that this is really a very good drug or very good option. But somebody requiring frequent oral steroids for these symptoms should be given this.
So in the same line, what is the role of injectable triamcinolone we use now? Triamcinolone acetate.
Yeah, Abhijit, you can take this.
Yeah, so this was used earlier, I believe. Now that we have a mainstay of being any sort of control over both of these diseases, whether it's allergic rhinitis or whether it is asthma, you have better oral corticosteroids or injectables available. So triamcinolone has really actually faded away. But probably it was used earlier where we didn't have the long-acting steroids available, and also steroids not available in various routes. So we didn't have any as many inhalers as we have right now. We don't have as many intranasal steroids that we have right now that was available in the past. So I think the injectable triamcinolone, again, probably reserved for more of the dermatological side issues that are faced by allergies.
One more question. What is the present and future role of component testing in allergy?
Yeah, so it is a good question, and yes, there is a definite role, and it is coming up with more awareness among the general population also, as well as the physicians and the ENTs. So there is, it looks like, it is definitely going to pick up with time, and it is going to be an important investigation in diagnosing and treating patients.
So what is the role of alternative therapy in the management of asthma?
Yeah, when it comes to management of asthma, we know India is a diverse country with we have seen the use of that fish therapy from Hyderabad. So a lot of therapies available during the I think Kozagiri day, that day the full moon falls, and then a lot of preparations being made that day to prevent and control asthma. So alternative therapy, India is I think the host of alternative therapies, because people believe in alternative therapies more than the real world evidence or scientific evidence for asthma. And the alternative therapies, as always, they proclaim that asthma ko jad se mitayenge, which is not possible with any of the allergies. We all know how it behaves, how the memory cells in the body behave and what they do, what is the exponential response that keeps on happening once for all when somebody is allergic to something. So people go for homeopathy, Ayurvedic therapy, as well as some other alternative therapies. But when it comes to an acute exacerbation of asthma, I am sure that no other therapy helps but the allopathy therapy, the inhaled medication, nebulizations, and then parental corticosteroids, as well as the ICU care that is there for such patients. So I personally don't feel any role of alternative therapies, but yes, homeopathy, Ayurvedic, they have their options available for asthma, but I would not definitely go for it.
Sir, I think we have one last question. There are so many antihistaminics available. Since this program is sponsored by Sanofi, I just want to ask you, which is the best antihistaminic, because newer thing than our old age-old levocetirizine, cetirizine, dexoquinidine. Which you think is the best?
Yeah, so see, when the number of options increases and the evidence goes in favor of one from another to another. But I think you cannot fix a single drug for a single patient. It has to be tailor-made for the patient as well as for the presentation with which he is coming. If you find that the patient is an elderly guy who has already a comorbidities and underlying cardiac issues, we need to be very, very selective in choosing the antihistamines. We know what can happen with the drug-drug interaction, as well as it can lead to potentiation of some arrhythmias, which can be life-threatening to these individuals. So whatever the trials has shown as the cardioprotective effect as well as less sedation effect, so all those should be preferred, but it depends on your practice also, what drug you are familiar with and what you have found beneficial. I think Mitul and Abhijit also can share on this.
Yeah, so in my in experience, I mean, personally, to my first or I mean, my go-to drug of choice is generally a fexofenadine with a Montelukast. It takes care of the acute symptoms also, and it helps in maintenance therapy as well. Also, it is non-sedative. Now, there are a lot of studies and a lot of molecules, people who are coming up with bilastine. But in my personal experience, my first choice of drug would still be a Montelukast with a fexofenadine.
Likewise, fexofenadine is shown to be even superior with combination with the bilastine. If you're looking at combination with an LTRA, as I'd shown in the studies that I quoted, for now, the newer antihistamines like bilastine still probably need some time, or probably we need to still get to know whether it is as beneficial as the data that we have on fexofenadine. Levocetirizine is effective, but it does come with its own side effects that you need to monitor. Can't be offering it to patients who are like type 2 respiratory failures having, we need to keep sedatives off. So yeah, personally, probably fexofenadine is what is preferred by me too.
Thank you very much.
I had a question for Harish Chaple, sir, if you don't mind. Sir, in your experience, is there any role, or have you seen whether an influenza vaccine or some helps in reducing or controlling symptoms of allergic rhinitis or asthma?
So actually, we all know the vaccination in patients who have chronic lung disease or allergic rhinitis or asthma COPD. It is definitely a recommendation to take influenza vaccine so that the exposure is prevent. So the frequent exacerbation that is thought to be because of exposure to these organisms, they can be prevented. But if you see just allergic rhinitis improvement with the vaccination, I would say no. But repeated exacerbation as well as admission rate and frequent requirement of the steroids can be prevented so that the baseline functioning can be maintained properly and the disease can be maintained at this level. But yes, I will definitely recommend vaccination to them.
Thank you.
Okay. One question from our panelist, Dr. Kashyap. How effective is nebulized formoterol in an acute attack of asthma? Anyone? You could hear the question?
No, can you repeat?
How effective is nebulized formoterol in an acute attack of asthma? Versus salbutamol.
So these are two different group of agent drugs, basically short-acting beta-2 agonists. Initially salbutamol, now we are all using levosalbutamol as a rescue medication. So short-acting beta-2 agonists definitely will be the first choice if it comes to relieving the acute symptoms in any patient who come to you with asthma. On the contrary, we advise to repeat it back-to-back for 3 nebulizations so that effective control comes and the symptomatic improvement happens with them. Now there are studies with R-formoterol nebulization and formoterol nebulization and other areas basically also. So I would definitely go for a short-acting beta-2 agonist initially upfront and then think of other agents like formoterol and formoterol.
Thank you very much, Dr. Chaple. It is always nice to learn from you. In all these webinars where we had on with you, we learned a lot. And of course, Dr. Mitul and Dr. Abhijit, you are excellent. Again, you are young people and lot many years to go. And I wish you all the best. And now I request our Joint Secretary, Dr. Pragji Vaja, to give a vote of thanks.
Good evening all. I would like to thank our speakers of today's webinar, namely Dr. Harish Chaple sir, Dr. Abhijit Ahuja, Dr. Mitul Bhatt. I also thank our knowledge partners for the day, Sanofi India Limited. I thank Mr. Dipen Mehta, Ms. Aditya Kuche and Ms. Vaishali Tanpure from DigiShield who have given us the platform for this webinar and handle all technical details at the same time. I also thank Dr. Kajal Ahuja, Assistant Director, IMA CGP, Mumbai Sub-Faculty, for conducting this webinar smoothly and efficiently. A big thank you to Dr. Sudhir Patil for being MMC observer for today's session. Last but not the least, I thank you all delegates for participating in this webinar in large numbers and making it a grand success. Thank you very much. Thank you all.
Thank you very much, all the speakers. Thanks a lot.
Thanks.